So today I'm going to talk a little bit about alcohol withdrawal and alcohol use disorder and management in the ED. People who saw me do grand rounds last month at the Poison Center, there's a little bit of repeat, but good space for repetition and a bunch of additional stuff, kind of squeezing in two lectures into this one. Uh, so no disclosures. Our objective is to get everybody feeling comfortable initiating medications for alcohol use disorder in the ED, to feel comfortable managing alcohol withdrawal in the ED, and to feel comfortable disposing patients with alcohol withdrawal in the ED. Little quick outline. So just a little bit of pathophys, not going to go too deep. Diagnosis, withdrawal management, medications for alcohol use disorder, and like a little bit of how to go through it. So first, pathophysiology. I spent too much time making some animations here. The real two main neurotransmitters we think about are glutamate and GABA. GABA is kind of, that downer type one, and glutamate's more excitatory. And at our normal resting time with no alcohol, we're kind of in a neutral, unless, maybe you're placed into 18 hallway and a little extra agitated. But when you have alcohol, that increases your GABA tone and decreases your glutamate tone. It's GABAergic and anti-glutamatergic. Over time, most of us, maybe this is how we like to drink our alcohol and how we like to feel, but if we're not drinking every day frequently, we don't develop tolerance. But over time with tolerance, you develop, and we don't need to go too deep into it, but essentially your resting GABA tone goes down, you decrease your receptors, and your resting glutamatergic tone goes up because you're trying to always be in that neutral with some baseline alcohol. And this is important for how we end up treating alcohol withdrawal. So, what happens if I take away alcohol? And this is why people are so agitated with alcohol withdrawal, because now you have excess glutamate and you don't have enough GABA. And so that puts you more in this hyperactive um, spectrum of kind of your general state. Now, we can use this for how we mostly treat, oops, alcohol withdrawal. Sorry. And the way we would treat alcohol withdrawal is by giving a GABAergic medication. Mostly, we'll talk a little about some other options. And here you're trying to increase the GABA tone to oppose the glutamatergic tone and to make you more neutral. Most of the time, because GABA is not perfect, we're not using anti-glutamatergic medications for the most part. We're going to end up actually making people more sedated. And this neutral one is probably not always realistic. But this is the basic theory of how we're going to address our pathophys of alcohol use disorder and then treat alcohol withdrawal. Diagnosis. So our main ways of identifying alcohol withdrawal. The first one, I think we're most obviously sometimes seeing is tachycardia or hypertension. So you get some sympathetic, increased sympathetic tone. The most common finding for most people, but I don't find it to be individually super helpful, is agitation. And a lot of people will use RASS alone to actually classify how severe somebody's alcohol withdrawal scale is. And this is how we do it in ICU settings. It's how we actually did it on the TOC service and our observation service at Rutgers in Newark. Pretty much pure RASS. It definitely has some flaws. People might have seizures. This is usually a slightly later finding, but can be early. Nausea, vomiting, diaphoresis, tremors, not so much the classic fasciculations that we talk about. The tongue is not any way unique compared to the rest of the body. It's just that most people aren't purposefully trying to maybe showcase a really extreme tremor. And then when you ask them to open their mouth and look in, hopefully they're not aware that you're looking to see if they're having tongue tremors. And then delirium, hallucinations. This can even be like formication, the sensation of bugs crawling on your body. This is a much later finding, especially the delirium component. Now, how might we risk stratify people? One thing I always want to remind people, and this is important for opioid withdrawal as well, is cows and SIWA do not diagnose alcohol or opioid withdrawal. You need to have already diagnosed the person as being high risk for those withdrawal syndromes, and you're using these to say how severe their alcohol or opioid withdrawal is. Some people will apply Siwa or apply cows to say this person has alcohol withdrawal or opioid withdrawal. And a lot of other things could actually cause their Siwa or their cow score to be elevated. They're very non-specific. So you need to apply them to the right patient population, which is somebody that you think is a high risk for alcohol withdrawal. RAS, as I already mentioned, just purely agitation to sedation. Negative, are you more sedate? Positive, are you more agitated? And then BAWS, which is actually I find maybe to be the simplest. It's the brief alcohol withdrawal score. Um, it's really RAS plus a few specific symptoms of alcohol withdrawal. Um, I wish we could do this and have our nurses doing it, but I got in a lot of pushback. But this probably helps you get around some of the problems of RAS of being purely agitation, as there are some kind of happier people, and it gets away from some of the complications and inter-rater reliabilities of SIWA. On the left, you see a cat there and its paw because there's the prediction of alcohol withdrawal score, and that's the pause. And so that you use theoretically to predict somebody's risk of developing alcohol withdrawal. The studies that it's been mostly looked at are at patients who have been admitted already. So this is not a patient you're seeing in the ED and necessarily saying they're going to develop alcohol withdrawal, but it's reasonable for us to use at certain specific settings, and especially if you're admitting the patient and you know they have alcohol use disorder and you want to tell the inpatient team, and maybe part of your justification by Millman criteria of saying why this patient should be admitted for their other problem because they're also at high risk of developing alcohol withdrawal. So these are some important tools. All of them are in MD Calc. So how do we treat? I've already kind of touched upon this. Benzos are probably the first line treatment that we've been doing for years. We actually switched from barbiturates to benzos and saw improvements in outcomes. And this was very long ago. The teaching that I learned all the way back in med school is if I only had two benzos, I really just want diazepam and midazolam. And then for alcohol withdrawal, those are the two most important ones. Midazolam is super fast onset, both IV and intramuscular. It's relatively short acting, which is its one disadvantage for alcohol withdrawal. Diazepam is long acting, great IV medication, perfectly reasonable oral medication option. It is a terrible IM medication, so do not consider it. Chloridase epoxide or Librium, actually the first and oldest approved benzodiazepine. And it also has, just like diazepam, it's long acting, it has active metabolites. It's one of the reasons why we really like it and why you see us using it. This only is working on GABA. Um, this has some disadvantages. It specifically requires GABA to be present for the channel to open. So for people who have been having prolonged withdrawal, inadequately treated withdrawal, sometimes people can become benzo resistant, and this can be one of the problems. It increases, and this can be on a test, it increases the frequency that the chloride channel opens as opposed to prolonging its period of opening. And again, you need GABA to be present. Um, whether you're using diazepam or Librium, there's really no difference orally. I would just say whichever one's available because we often go through shortages. Just to touch on lorazepam a little bit, because you see it's not there, and that's obviously what a lot of our medicine colleagues are always pushing for. Um, it's not a terrible medication. It's intermediate everything. So it has intermediate onset of action. It lasts for an intermediate period of time. It doesn't have any active metabolites. It is okay. I'd rather it over diazepam, and it's pretty good intravenously. Um, it's will be pushed sometimes for patients with liver dysfunction because of the LOT medications or the non-liver hepatically metabolized benzodiazepines. We, from like the tox world, will, so my opinion is that I actually choose diazepam because I want it to last a really long time. So if somebody has some liver dysfunction, that can be a benefit as long as you're closely titrating them. Phenobarb, the new, what was old, which is new now. As I mentioned, barbs was how we were treating alcohol withdrawal way, way, way back before benzos existed. Um, I think they're really great medications. It was one of our graduates who was a chief my second year, who I think kind of first brought it back to county, Dr. Racinti, for those who know or remember him after he went to Denver. It has really great mode of action. It works on GABA, but unlike benzos, it actually will open the channel regardless of the presence of GABA. So you can give it even for that GABA deplete patient who's been seizing and having prolonged withdrawal or inadequately treated withdrawal. It can synergistically work with benzos because unlike benzos, which increase the frequency of opening, it prolongs the period that they're open, and they work together more synergistically than just additively. One thing I do want to say is you might read that it works on glutamate. It does work on glutamate, but the receptors that it specifically works on seem to be AMPA and kainite receptors. These are more minor receptors from the alcohol withdrawal standpoint. There is some involvement of kainate, but the NMDA receptor is the main receptor that we are dealing with for alcohol withdrawal, which phenobarb does not have any activity against. So, you might read on EMCrit or hear in other blog posts or that it's great because it works on both sides of that alcohol withdrawal and pathophysiology that we talked about. But in reality, it's really only working on that GABA side. It is a little slower onset than our benzos, so 15 minutes for onset, 30 minutes to peak. It is a pretty avid CYP system inducer, especially CYP3A4, and so you do have to worry a little bit about them being on other medications. It lasts a really long time, and so it can have that really nice same characteristics even longer than diazepam, where it'll be there for a long time for like a self-titration. Ketamine, this is our main medication to treat on that anti-NMDA side. This can be great to combine with our benzos or even our barbiturates, our phenobarb. I am rarely going to this as a first line. It is a good medication to, add on, especially when you're intubating a patient. We're doing the kind of ESET equivalent for ketamine right now. I was it ECET? I don't know if Dr. Zaptachi's on to comment. One of the big issues that a lot of people had in the tox world from ESET was when they did a subgroup analysis trying to say that levetiracetam would be good for tox-related withdrawal syndromes. The biggest group of the subset of people who had a tox diagnosis were alcohol withdrawal, which levetiracetam is not a great choice for that. Um, Ketamine would actually be a lot better. And so if you're really thinking about somebody who didn't respond to benzos, and we know from ESET that a lot of those patients actually end up, even though we don't realize it at the time, as having alcohol withdrawal, ketamine is actually a really good choice to be treating alcohol withdrawal and benzo. So maybe a good choice to be using for the undifferentiated seizing patient with status who's failed benzos already to consider ketamine as your antiepileptic. That said, phenobarb is also a great antiepileptic, and so I wouldn't write that one off, but ketamine's a little faster onset. We use it intramuscularly, rapid onset in that setting, which phenobarb we're not using in that way, and it's not as rapid onset as I mentioned. We can certainly talk a little bit more about this later. Propofol is probably in some ways our most beautiful medication because it actually works on both sides. It's both anti-NMDA and GABAergic. This medication is I'm mostly or exclusively using when they're already failing my other things and I'm deciding to intubate them, obviously. But it is just like alcohol, covering everything, and it does not need GABA to be present. So it's useful when you're moving to that severe treatment spectrum. Just to mention, dexmedetomidine, Precedex, our ICU colleagues are using it. There are studies that show that it reduces benzo utilization and possibly some degree of like benzo-related delirium. It the concern that a lot of people in the tox world say have, and even the addiction world, is that it is not treating any aspect of withdrawal. It is covering up a lot of those symptoms and a lot of the vital sign abnormalities, which means that you're by not going to be giving symptom triggered therapy. So you're not going to be able to identify worsening withdrawal because you're kind of hiding it is our concern. Now, the question is that causing harm to patients? And we do know that patients who are having seizures, who are having non-convulsive status, are more likely to have kindling and to have longer term issues with seizures. And I would say I would avoid dexmedetomidine. I think you can use it responsibly in an ICU setting, potentially, you know, but I would focus on our anti-NMDA GABAergic medications and figure out where this can fit sometimes with our ICU colleagues, but not in the ED. And then gabapentin, we also had a great speaker. I don't know, that must have been like 6 or 7 years ago. Dr. Willis would remember talking about gabapentin is actually monotherapy for alcohol withdrawal. Unlike the name gabapentin, it has no actual activity on GABA. Um, it seems to work more on like calcium channels. It's not really an AED. We'll talk about it a little bit more in the context of medications for alcohol use disorder. There are studies that show that for withdrawal, it can be used as monotherapy, especially in mild withdrawal, and most of those people are still drinking, but I would not use gabapentin as a monotherapy for alcohol withdrawal. Okay. The other side of this talk isn't just how we're treating withdrawal, and we could have a much longer, much more in-depth conversation about withdrawal management. But I do want to talk about medications for alcohol use disorder in the ED, because this is like becoming a more and more important thing, similar to what we do for medications for OUD in the ED. So why is this important? Well, 44.5%. So that's, 45% of people who are dying from liver disease is due to alcohol in the United States. That's a pretty huge number. Alcohol has a huge impact on people's lives, mortality and morbidity, and we see a lot of that in the ED. A lot of our goal is to prevent people from worsening and having to represent. So we do a lot of treatment for OUD in the emergency department, but we don't do a lot of treatment for alcohol use disorder, for AUD in the emergency department. And, we've all done the wake up in the morning, time to go, sign out MTF, metabolize to freedom, which I think has become a thing that we're not supposed to be saying anymore. It's become an issue, actually, I think, with JCO. And one of my mentors back from med school, Dr. Lagasse, who's doing the OUD sim, and I'm working with him on that, has come up with a new term which I think is great, which is interview or medicate when awake. So when the person's awake and they've metabolized, that's the time to talk to them because you're not going to talk to somebody who's intoxicated. But we're doing so much with OUD, but what's the burden of disease? Well, the burden of disease is 178,000 people are using alcohol in a year. It's a legal thing, so that's not surprising versus 9 million. But even people who have alcohol use disorders, that's 23 million people versus almost 5 million people. And then looking at emergency departments, so visits, so that's obviously our house. We see this all the time from the person who falls off their stoop on the street, goes to a party, gets a laceration repair, whatever it might be, maybe has an intracranial hemorrhage. There's 4 million ED visits for alcohol related injuries and presentations versus 2 million. 2 million hospitalizations versus 1.3 million, and 178,000 attributed deaths versus 74,000 deaths. This is not to minimize OUD, it's just to show that this is a big area that we should be doing a good job focusing on. And even more importantly, of why we should be doing this is because fewer than 10% of people are actually receiving treatment in the past year for alcohol use disorder. So there's a lot of people we could be addressing, and we are the gateway. Almost everybody who's going to develop liver disease and require a transplant or die or have that, intracranial hemorrhage or have something else is going to have presented to the emergency department before those things develop, so we can stop it. So let's talk a little bit about medications for alcohol use disorder. I'm first going to talk about only two of the FDA-approved medications. There is a third. I honestly don't even think it's worth mentioning. We can talk more about it. Disulfiram, Antabuse. There's no reason to really consider it. in general, not even just from the ED. There's few very specific cases, but I'm just not going to really talk about it. So the first one worth mentioning is acamprosate. Um, this is the second approved after disulfiram medication for alcohol use disorder. It's been around since I believe the 50s or the 60s, so it's been around for a while. We're obviously not using it that well. Here's a nice, good systematic review and meta-analysis showing that it has an NNT of alcohol of cessation. Its big issue, though, is that people just have issues staying with therapy. You have to do it 3 times a day. And honestly, I don't know whose weird joke it was, but the dose, it's the easiest to remember. It's 666 milligrams, 3 times a day. If they have renal dysfunction, you can reduce it to 333 milligrams 3 times a day. You will not forget this dose. But anything 3 times a day, it's like I'm always trying to be annoying and tell people cephalexin 4 times a day for a UTI is not going to be taken. And just as 3 times a day, dosing of a camper set is probably not going to be taken. So that's its big issue. The bigger, more popular thing on the block right now is naltrexone, which is similar to naloxone. It's a long-acting mu opioid receptor antagonist. It's actually semi-synthetic. If you know what, say, morphine looks like, it's a very similar structure. It's actually derived from thebaine, which is another one of the naturally derived alkaloids. This is the third approved medication. It's in both an oral and a long-acting injectable formulation. Uh, and you could imagine what probably would be its issues. The way it works is kind of interesting. It probably is doing something and just taking away our pleasure from activities, whether it's drinking or even maybe opioid use or gambling. So it's been used in a lot of different addictions and use disorders. And when we give it to people who are on like a treadmill or an exercise bike, they actually will stop their activity sooner because they're not getting pleasure. They're not getting the runner's high or the biker's high. And that's probably how naltrexone's working. The NNT actually looks a little less impressive. Um, when you look specifically at reduction in heavy drinking, it's a 6 for the 50 milligram oral. The 100 milligrams you see actually has a higher NNT, which might just be less compliance. It's not entirely clear. Again, you're not getting the pleasure in life that you might normally, and so it might just be less well tolerated having the larger dose. Not entirely clear. It is once a day, though, if you're doing the oral, and you can do a long-acting injectable monthly. The big question that I think comes up these days is should we be doing the long-acting injectable? So everybody's probably familiar with the SAM GRACE guidelines. Um, they actually end up saying we should be doing the long-acting injectable from the ED. It's not based on very strong evidence. This is the main study. This is actually by D'Onofrio, um, who is the same famous author who we actually had do grand rounds a number of years ago, probably like 4 or 5 years ago, and did the paper, the seminal paper on essentially buprenorphine from the emergency department. She's the former chair at the Yale ED. Department of Emergency Medicine, and it's also with Andrew Herring. This is a non-randomized study. It's letting people choose whether they want to be an oral or long-acting injectable, and they had better follow-up rate is really the only thing that they're showing better with the long-acting injectable. So this, to me, is not very convincing. Some people are even choosing oral. So I would say it doesn't make a big difference. That said, H&H does not want us to be doing the long-acting injectable from the ED. They can figure out how to bill it, I guess, better from the outpatient. We do have ways to do it if everybody decides, and that's going to be made a little clearer in the future, not in today's talk, but we'll be releasing some updated guidelines um, for how and protocols of how to do it in the ED. But it's over like 1,000 times more expensive. And they're not able to even get fully reimbursed if we do it in the ED. So oral probably fine, and the evidence supporting IM is not really good evidence to support it. So another thing that you might consider is topiramate. This is becoming a little bit more common right now because acamprosate has actually been on um, drug shortage or very expensive to get. So if you have a contraindication to naltrexone, which we'll mention a little later, mostly if you're on an opioid, um, then acamprosate is often where we would choose. If you're not able to get acamprosate, topiramate. Problem with topiramate is had a lot of side effects, but it is 2 times a day, so people seem to stay with it pretty well. It does seem to work. I said I'd mention gabapentin again. This is a good, interesting paper looking at alcohol. Um, Specifically looking at gabapentin as a medication for alcohol use disorder with patients with severe alcohol withdrawal symptoms or history of. And what they end up showing is that NNT not so great if the person has no history of having like seizures or severe alcohol withdrawal, but specifically does have a pretty good NNT of 6 if, or sorry, NNT of 3 if they have that history of severe alcohol withdrawal syndrome. So maybe something to consider as an addition to naltrexone or a Camprosate, especially in the setting of somebody who has that history of severe alcohol withdrawal syndrome. Um, Gabapentin does have a lot of side effects, so I don't know if I would just throw it at it. I know that is what a lot of people are doing, and our current guidelines that'll be coming from central office are maybe going to be a little bit more aggressive of everybody getting it. But the real population you should be thinking about this for are people with severe alcohol withdrawal, history of severe alcohol withdrawal. The most important thing probably for all of this is that you do refer people. Um, every study that is looked at for medications for alcohol use disorder, this is not just taking a daily medication. It also includes um, working with a intensively with an addiction specialist, maybe doing other forms of therapy and DBT. So it doesn't end with us. So that same catch consult, behavioral health follow-up is super important. And though I don't mention it here, another thing you could even consider is Ozempic. There's some studies showing that the GLP-1s work really well for all forms of addiction. And the one good study does seem to show reduced drinking, but the big outcome is they all lost weight. All right, so let's move a little bit on to our kind of how we're going to treat patients coming to the ED for alcohol withdrawal. This is not yet fully published, but I do want to include it. This is going to be kind of our treatment algorithm on our observation unit at Kings County when we are able to roll out alcohol withdrawal at county on the OBS unit. These numbers are all kind of assuming that people are already being treated up front for alcohol withdrawal, which we're going to move on to the next slide about. And so they're a little lower than what I'm going to mention. And I only say that because I'm going to say numbers that are a little different. And people are going to be going to the OBS unit having already had a CWA score now less than 8 after treatment. And we're going to have a good table for you to know how to convert depending on which benzo you're using, because we're not telling you what you have to do. All right, so how do we treat that patient who's severely agitated? Um, so this is somebody who has a RASS of greater than 2. First, maybe you don't know they have alcohol withdrawal and they're totally undifferentiated. A benzo like midazolam, you can't get an IV, they're coming in through CCT. This is one of the reasons why midazolam is a great choice. Because if you don't know what's going on and it is alcohol withdrawal, it'll treat that. Ketamine, equally as I said, will do that. I'm a big fan of droperidol. It actually won't, and this was a topic of debate at the most recent European Tox conference, and Bob Hoffman took the midazolam point of view. I forget who it was from Australia that took the ketamine, and Isbister, who's known as the author of the Dorn study, which is the droperidol study, kind of took the droperidol. And they had a lot of patients with alcohol withdrawal who got droperidol, and they did well. But we're talking about alcohol withdrawal. If you know it's alcohol withdrawal, you should start with a benzo or ketamine. Usually that's giving 10 milligrams of IM midazolam if no IV is available. And you can rapidly titrate that and hopefully you're able to get control and you're able to give them get an IV, and then you can do phenobarb, you can do diazepam, which would be my preference from a benzo standpoint. Now, if you do have an IV, they're not severely agitated, they've had a seizure, and so you're able to get IV access. Phenobarb, 10 mg per kg, is probably the most thoroughly studied. There's good data to show that you can titrate 260s, and actually that's the way that we're going to be doing it at County more. And I myself, and I don't remember who it was with, have ordered 10 mg per kg, and it has to come from the pharmacy. It has to come from the mixing room. And so when it comes from the mixing room, it takes a while. And if we give a 260 bolus, and you can even order, say, three 260 boluses for a person who is 780 kilos, or not seven, like 75 kilos, a 260 bolus would be a total, or times three would be totally reasonable to give them. So that's 780 milligrams for that 75 kilo person, and you can rapidly titrate up that way. It is a little slower onset, so you might want to give 10 milligrams of diazepam up front. You could also say, I don't, I'm not used to phenobarb. I'm not going to give a full 780. I'm going to give only 260, and I'm going to wait 15 minutes, and I'm going to repeat another 260 and wait another 15 minutes. And I'm going to give another 260 and wait 15 minutes and be very aggressive early and upfront. And if they're not responding as quickly as you want, add on benzos and potentially intubate them if they're still having seizures, if they're still agitated. And I would say for me, if I've given them 15 mg per kg of phenobarb, if I'm giving them around 100 mg per kg of diazepam equivalents, that's when I'm really starting to pull that trigger on. I think I'm going to intubate them and give them propofol. But often, kind of combining the two medications can have a lot of efficacy, as I talked about, synergistic. Um, in some ways, the severe withdrawal are the easiest, but they're the hardest because when you get behind, that's the worst. So you need to be really aggressive up front. And we're in CCT, and or you bring them over to CCT and you're just ready to take their airway if you go a little too far. But you're more likely to cause harm in going too slowly. Um, Mild withdrawal, this is somewhere in between. Maybe they have a RASS of 1, 2, with some vital sign instability, maybe a little bit of tremors. If they can take oral's probably totally reasonable for this person. Maybe they have a contraindication because they're going to the OR and that's why they're developing withdrawal, or they were intoxicated, fell, and now they're in withdrawal. And so you can't give them oral. I generally will start if somebody's in actual mild withdrawal with 100 chloridase epoxide orally. You can always be giving 10 milligrams of diazepam initially and titrate every 2 to 5 minutes. Midazolam, you're giving generally 2 to 4 milligrams, titrated every 2 to 5 minutes. Um, and you do want to be, a little quick about it, but these patients' oral is totally reasonable. Um, and you will escalate and keep moving up if they're not getting better. But most of the mild patients, hopefully with 1 or 2 rounds, a single 100 milligrams of chloridase epoxide will do well. You could also give them, 259.2 milligrams oral of phenobarb. Um, Phenobarb's a little annoying. It's done in grains, and so one grain is like 64. I think it's like 64.2 milligrams. And so the pills are done in these weird divisions of grains, and this ends up being this 259.2 is 8 pills, 865-ish, 64.2 milligram pills is what you end up giving them. So just when you do the order, if you order it as a full 260 orally, you're going to get a message from the pharmacy. So it's going to delay them getting it dosed because they'll say, I can't give that. I'm not going to cut a pill to get zero point 0.8 milligrams. You can just give the 260 IV. If it's very mild, maybe you're doing 130 instead. It's a little slower onset, so you're waiting 15 to 30 minutes. The orals are all a little slower. So for phenobarb, It's very similar, like 80 to 100% bioavailability, but you're waiting 30 minutes to 60 minutes to redosing. And that's the real disadvantage sometimes of doing oral. But people are less likely to become sedated. And then the third category are the super mild to no withdrawal. And this might be the patient who you're doing another workup for, or who you're admitting and right now doesn't have withdrawal, but you did your pause score and you're saying they're probably going to develop withdrawal. They're in the ED, you got signed out, as I said, don't do the MTF, but how many patients, are waiting overnight and develop withdrawal before you discharge them? And so I think we all sometimes give these patients oral benzos for the purpose of preventing them from having withdrawal while you're completing their workup or allowing them to stay overnight. But this is also a good thing to give for that patient you're admitting who maybe isn't going to have all their orders put in right away and have identified withdrawal immediately because they're not being watched as closely as they would be by us. And so it's important sometimes to be giving them that. And this is, you might half those doses, like you have no withdrawal. Maybe you don't have a very severe history of alcohol withdrawal. Your pause score is not super high. 50 milligrams of chloride, epoxide, or Librium. If it's maybe a more severe history, maybe go for 100. If you know what their alcohol level is, you might adjust it a little bit there. Um, and then phenobarb giving them that, 259.2 or, 4 tabs to give that almost 130 dose are also reasonable ways to give somebody a little bit of prophylaxis of withdrawal and to begin a little bit of treatment for the patient coming in so they don't develop it while they're waiting to be followed. Now, where do the patients go home? Where do they go? So home in some ways is easy, but also really hard. If you're able to tolerate PO, they've gotten treated, it's very mild, or they never had it and you were just giving them kind of prophylaxis, they can go home, but you do always need to ask, and this is not necessarily is the patient's withdrawal well controlled enough that they can go home, but why did they come in withdrawal? So if they were brought in by EMS, if they were brought in by, NYPD, and the only reason they're here is because somebody called 911 for them sleeping on the street, and you talk to them, they say, well, I intend to continue drinking. I don't have access problems to obtaining alcohol. Well, that person maybe can go home. Well, we obviously are going to talk a little bit more about the medications for alcohol use disorder and why you might consider having that conversation and maybe consider initiating therapy there. Um, but they can go home. But if a patient has barriers to obtaining alcohol, to continuing drinking, or just has no intention of continuing drinking, well, that patient you might not be able to send home, even though from their withdrawal standpoint, you're able to just give them 100 chloride epoxide. They're not requiring repeat doses. They have no high risk features. They haven't had a seizure. Their vital signs are stable, but you can't discharge them because they're not going to drink. Now, maybe you work with the addiction team. Maybe who you're working with is okay ordering a Librium taper, chloride epoxide taper, but I think that's pretty uncommon. Um, and I think there's only a small subset of patients that most of us would feel comfortable discharging with a prescription for benzos to take at home. Some people might consider doing phenobarb. Again, it has that really long half-life, and so you might give them a larger dose of phenobarb with the idea that it self tapers. And a lot of the papers that Dr. Racinti had brought up then kind of, and there has been more studies showing that patients do pretty well when discharged on phenobarb and don't come back with severe alcohol withdrawal. But you do have to have a plan. Um, if the catch team, the addiction team, is going to see them right away, and there's decision that they are safe to go home, even without their plan to continue drinking. But that is an important barrier to consider. That's not just purely your management of their alcohol withdrawal. Coming into the med surge in a similar way, sometimes the patient's going to be that patient who medically is totally fine going home, but is not going to drink, has a barrier to drinking, and so can't go home. Maybe they're coming in, as we talked about before, for a not alcohol withdrawal related reason, trauma, they have appendicitis, they have a pneumonia that they can't go home for, whatever it may be, that patient can go to a normal medical surgical floor. If you're not requiring increasing doses, I would generally say if I haven't had to give them around 70 milligrams of diazepam equivalents or more than 10 mg per kg of phenobarb, I'm probably saying I'm not even thinking about the ICU at that point. If I haven't had to redose them after getting that amount, I'm just going to talk to medicine and I'm going to let them know that I'm concerned about withdrawal or that's why they're coming in and they need to keep dosing them. Um, but there is a gray line, and don't be surprised when medicine says, I want ICU to see them. Pause score can be really helpful for here, where you can say their risk of developing severe alcohol withdrawal is lower. If somebody's having alcohol withdrawal and their alcohol levels over 200, even over 100, I'm starting to get a little bit more concerned, and that person I might end up just consulting ICU on. So it can be a little subjective in this barrier, and a lot of people will have a little hesitation in taking the higher benzo requirement or phenobarb requirement patients directly to medicine. But 10 mg per kg should be fine to go to medicine, a phenobarb, and around 70 to 100 of the diazepam if you're not requiring continued dosing, they don't have vital sign instability, and you're not obviously intubating them or having ongoing seizures. One seizure that's not repeating after treatment, it can be fine to go to medicine. And then, the ICU patients can be complicated. Obviously, if you've intubated them, if you're using um, propofol, if you've gone to ketamine, I'm calling them, that's an unconventional thing that we're not doing that frequently. Once I've given them 15 mg per kg of phenobarb, even though they might end up being okay if they don't need any repeat dosing, and that's just my second dose is that 5 mg per kg, I'm calling the ICU. I'm letting them be aware of the patient. And then if they don't need to get redosed, they're probably going to end up rejecting them and having them go to medicine. Um, if they're having ongoing vital sign instability, if they're honestly, if their RAS is too low with all the medications you're giving them and they're not tolerating PO or they're not awake and with it, that's another patient that you really might want to consider the ICU. Or if their other medical problems require them to go to the ICU. But this can be a little bit more complicated. So, which medication for alcohol use disorder should you consider? It's almost always going to be naltrexone. Um, we have a much larger growing body of evidence for its use. It's once a day or once a month if you're using the long-acting injectable, so it's easy for patients to use. They seem to have pretty good satisfaction with it. The one big thing to worry about is patients who have opioid use disorder. Um, if you give somebody long-acting naltrexone, especially, you will give them the worst withdrawal of their life, and it will be for longer than they've ever had withdrawal for. And that's very difficult to treat. And so the worst opioid withdrawal I've seen just about was somebody who incorrectly got long-acting IM naltrexone for alcohol use disorder without the providers realizing that he was on methadone. And you just have to give them buprenorphine, 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 because it's one of the few things that maybe you can crowd out the receptor. Um, if there's any question of whether or not they have opioid use disorder, you can give a IV intranasal dose of naloxone. You can even give an oral dose of naltrexone, which still has a long half-life, but not nearly as long as the intramuscular. And so they're not going to be in withdrawal for a month. Um, so if there's ever a gray area, you can consider that. If the patient uses benzos, especially street benzos, those are often fentanyl. And then the other category of patients that you're not going to be doing naltrexone for are surgical patients. So even recently, I had a patient I wasn't starting it on because I thought he might have to go to the OR. If you have a patient who has alcohol use disorder, has trauma, I'm not even going to think about giving them naltrexone because they're probably going to be needing opioids, and there's no reason to block the main analgesic that our trauma surgeons and all of our teams are going to be utilizing. If we're not doing naltrexone, then we're doing either topiramate or a camprosate. We're doing topiramate a little bit more often just because of the inability to obtain a camprosate. Um, and then, especially for the patients with a history of severe alcohol withdrawal, you're adding on that gabapentin. Generally not as monotherapy for their alcohol use disorder, but that's being added on. And some people are using it for everybody with a history of alcohol use disorder, whether they have that history of severe withdrawal or not, that they're always adding on the gabapentin. Okay. And in summary, GABAergic medicines are our first line treatment. Naltrexone is our first line medication for MAUD. Probably no real benefit to the injectable. You're supposed to be giving the oral anyway at H&H for cost reasons. Don't use when somebody needs opioids, whether for opioid use disorder or for as an analgesic. Acamprosate or topiramate would be our second line, gabapentin as an add-on, and really be aggressive and upfront with your treatment for alcohol withdrawal because that's where it gets the worst.